Dear colleagues, with this lecture we are starting our course of lectures about tuberculosis. I would like to stress that these lectures do not contain all the information you should know for the lessons. Their aim is to stress the main points and to explain some issues that can be probably difficult for understanding. I hope all of you remember that tuberculosis is an airborne transmitted infectious disease. TB can affect almost all organs and tissues except hairs and nails, though the most frequently involved area is of course lungs. Tuberculosis has a very specific histopathological manifestation, and we will discuss it a bit later in this lecture. I'm not going into details about the epidemiology of tuberculosis and the history of it. You can read about it in other sources that you can find in the course. But it is necessary to stress that tuberculosis still presents a challenge for global health care. That is why WHO approved the anti-TB strategy, which is the part of the Global Sustainable Development Goals. The main targets of this strategy you can see on this slide. You should know the classification of mycobacteria. To this genus refer not only tuberculous mycobacteria, but also Mycobacterium leprae and non-tuberculous mycobacteria. Some of the non-tuberculous mycobacteria are non-pathogenic at all, and some of them can cause non-tuberculous mycobacterial infections. Mycobacteria have some properties that make them a bit similar to fungi. They grow very slowly in the culture media, and they are highly resistant to environmental conditions. They are also quite polymorphic. High resistance to environmental conditions is provided by the cell wall structure. In this picture you can see that mycobacteria have a very thick cell wall which contains a lot of lipids and mycolic acids. Besides airborne transmission, there are some other ways of possible tuberculosis transmission, but all of them occur extremely rarely in comparison to airborne transmission. It is important to understand that tuberculosis is not spread with big droplets, and smaller droplets are produced only when an infected person coughs, sneezes, or speaks. Hence, even if mycobacteria survive somewhere in dust, it is not likely that this dust can cause infection, as its particles are not able to reach alveoli. The most important source of infection is air near an infected person who coughs, sneezes, or speaks, especially loudly. And droplets produced in this way can stay in the air for a substantial period of time, especially if it is an enclosed space with poor ventilation. Fortunately, tuberculosis is not a highly contagious disease, and the probability of getting infection depends on many factors. They can be classified into host factors, microorganism factors, and environmental factors. For example, from the previous slide, you can understand that the probability of being infected is higher if the contact takes place in a small room, especially with poor ventilation. An infected person can spread different amount of mycobacteria, and these mycobacteria can have different degree of pathogenicity. For example, if an ill person takes an appropriate treatment, the mycobacteria rapidly become non-pathogenic. It happens in case of drug-susceptible tuberculosis in 2 weeks after treatment. There are 3 main ways of what can happen after the contact of a TB patient and a healthy person. Most people will not be infected at all. Mycobacteria can be cleared thanks to mucociliary clearance. If mycobacteria still reach alveoli, for example, if mucociliary clearance does not work properly in a person, for example, if this person is a smoker, then they are attacked by macrophages. In many people, macrophages can kill these mycobacteria, and again, no infection will develop in this case. But sometimes macrophages cannot do it very quickly. Then, thanks to interleukins, they release T lymphocytes realize that their help is necessary. They come to the location of inflammation and activate macrophages through releasing interferon and other interleukins, thus helping macrophages to lyse mycobacteria more efficiently. T lymphocytes also build a kind of a wall around macrophages and mycobacteria to prevent further invasion of mycobacteria. From this explanation, you can understand the process of granulomas formation and remember its structure. In the center of specific tuberculosis granuloma is caseous necrosis. Then go macrophages and giant cells that are macrophages themselves, and then go lymphocytes and fibrotic cells. If the immunity happens to stop the infection efficiently at this point, and again it happens in most of those people who were infected, no active disease develops, but some mycobacteria usually survive in the organism, although they are inactive in this case. Such a state we call latent tuberculosis infection. People with latent tuberculosis infection are not ill people. They do not have any clinical manifestations, any symptoms, they do not have any radiological abnormalities, and they do not spread mycobacteria. But they still have alive, though inactive mycobacteria in their organisms. It means that at some point of their life, if their immunity decreases, these mycobacteria can become active and can begin replicating. And in this case, they will develop active tuberculosis. To conclude this part of the talk, active tuberculosis can develop right after the first contact, and we call this primary tuberculosis. And it can occur many years after the first contact as a result of endogenous reactivation and exogenous superinfection. The last 2 situations are similar in terms of their clinical manifestation, and usually these types of tuberculosis are less severe than the primary TB, as the organism already has a certain amount of immunity against mycobacteria. There are 2 main ways of tuberculosis detection: active TB screening and passive case finding. Passive case finding strategy supposed that patients are generally active care seekers who are examined for TB cases because they have symptoms compatible with tuberculosis. The weakest point of passive case finding is waiting for patients. As symptoms of tuberculosis can be very poor, and we will discuss it a couple of minutes later, or patients can be unwilling to seek for care. It is sometimes reasonable to use active case finding, especially in people from high risk groups. Clinical symptoms of tuberculosis are usually inspecific and not very vivid and acute. There can be signs of general intoxication. It means fever, usually not very high fever, fatigue, and weight loss. As lungs are affected most often, we usually see respiratory symptoms as well. If a patient has a long-lasting cough without any improvement after non-specific treatment, a physician should suspect tuberculosis in such a patient and should investigate such a patient to detect tuberculosis. In HIV-positive patients, the onset of symptoms can be acute and the course of the disease can be more severe and more rapid. Also, these patients are more inclined to have extrapulmonary tuberculosis. Often people imagine patients with tuberculosis as this one, but such appearance is specific only for patients with chronic tuberculosis, when they do not receive appropriate treatment for a long period of time. And most of the TB patients usually do not have any specific features in their appearance as this girl. And this painting is created by a well-known artist, Paulina Sinatkina, who was ill with tuberculosis, and she began portraying patients as she was in the TB hospital. Now she is an activist and one of the co-founders of the network for TB patients. Its name is TB People, and I highly recommend you to look at her other pictures. This is all about the main points of TB etiology, pathogenesis, and diagnostics.